Teach fertility awareness to your clients and master the skill of advanced chart interpretation. Learn to support your clients through their cycle irregularities and hormone imbalances with confidence. Our Fertility Awareness Mastery Mentorship is now accepting applications for our next class in January 2026. Head over to fertilityfriday.com/FAMMlive to apply today. That's fertilityfriday.com/FAMMlive. This is the Fertility Friday podcast, episode number 595. In today's episode, I am diving into AMH, anti-Müllerian hormone. This is an important topic for women who are trying to conceive, women who are struggling with fertility challenges, and for practitioners alike. And of course, the reason why it's such an important topic is because there are still many misconceptions about how this information, how this number should be used in practice. And it leaves many women feeling hopeless, feeling like they're not going to be able to conceive, all based on this number, this result. So we should really talk about what it really is, what it really measures, what the research tells us that it is best used and most useful for, so that we can be providing the best and most accurate information to our clients. And if you yourself are listening for gaining a better understanding of how this could apply to your fertility, then I think you'll find today's episode very helpful. So as always, I will link the paper that I'm referring to the show notes page, which you'll find at fertilityfriday.com/595. So the paper is called Evaluation of Female Fertility, AMH, and Ovarian Reserve Testing. So this is a review paper, and it's going through some of the latest research. It provides a really good summary. It's intended for practitioners and clinicians to clarify some of the most common misconceptions about AMH. And to start this episode, I think it's useful to share a little bit of background in terms of how common fertility challenges are. So it's estimated that anywhere from 1 in 6 to 1 in 8 couples are struggling with fertility issues. And as we've talked about many times on the podcast, although we tend to think of fertility issues as a woman's issue, up to 30% of the time, infertility is related solely to male factor, and about 50% of the time, so half, male factor is involved, and that it might not be the sole factor, but it is involved. And statistically speaking, when we're looking at couples who've been trying to conceive for a year or more, if we were to test his sperm parameters, again, statistically speaking, they're likely not hitting those optimal levels. One thing I'll mention is that these topics are covered a lot more in depth in Real Food for Fertility. The sperm chapter is chapter 11. Over 200 citations in that chapter going through what's normal, the normal sperm parameter. So I won't be going through that in today's episode. And in the egg quality chapter, you'll find a detailed discussion of AMH and other ovarian reserve parameters and essentially what the research says is going on there. So there's a couple other things. I mean, being a research paper, I think it's really helpful that they kind of go through some of the bigger picture challenges that could be contributing to the rise of infertility across the world. And I think it is worth mentioning that we know that there's a trend across the world for women to be delaying their first pregnancy. And it's interesting because the way the researchers frame it is that there is a lack of knowledge about fertility. And there are a lot of studies out there about fertility awareness, but not in the sense that we talk about it, which is the fertility awareness method, but generally awareness about fertility, how it works, and how it changes with age. So certainly one of the challenges of our modern era is that our bodies are primed and most receptive to pregnancy. Our natural fertility is the highest when we're in our 20s. And then, of course, even into our early 30s. But as we get into our mid to late 30s, there is this natural decline in fertility. And this is something that we should talk about. It's something that we should be aware of. It's something as women that we should be taught to understand. And of course, that's one of the topics I talk about a lot in my books and in my work, which is that when we are not taught about our fertility, but we're kind of taught we can get pregnant anytime, we're not taught that it changes as we get older. So a lot of women are essentially afraid of pregnancy for most of their life. And then when they're finally ready to start trying for a family in their 30s, they haven't been provided this information. And if we've been using hormonal contraceptives and suppressing fertility, we're also not taught about the fact that there is a temporary period of subfertility while our body adjusts, especially if you've used birth control long term. So if you've used birth control, in the studies, they define long term as 2 years. And that is, for anyone who's hearing that for the first time, it's often kind of shocking. Like, wait a minute, they define long term as 2 years when many women are using birth control hormonal contraceptives for, 5 years, 10 years, 15 years, 20 years. It's not uncommon, right, for women to be using it for that long. But if we don't know about that transition phase, then we don't necessarily know to come off birth control while we're still avoiding for, ideally, I would say, a year or two before you're ready to start trying to conceive, just to let your body kind of sort itself out so that you can actually see what your cycles look like and so that you can have a good sense of the lay of the land. If you come off of birth control when you're still avoiding, and then you and your partner are using non-hormonal methods that are not affecting your cycles, then if there was an issue with your cycle, you would have some time built in to sort it out. If you need to go for testing, if you need to work with somebody, you would actually have the time to do that when you're not also actively trying to get pregnant at the same time. And this is especially important for women that did have a history of irregular cycles or cycle abnormalities or hormonal disturbances, or if you had really severe PMS, if you had really severe pain with your periods, you would be in a category that would certainly benefit from coming off contraceptives early. And what I always say is that doesn't mean that you can't get pregnant right away. There are, of course, women who get pregnant while they're still taking hormonal contraceptives, but we want to be able to have a buffer period, kind of like how we have car insurance for when we drive. We don't want to assume the worst, but we always want to plan and we want to have a strategy in place. So getting back to this paper, that is one of the things that the researchers are identifying. Women are having children later in life, and a lot of women aren't really aware of fertility and how it changes with age. And interestingly enough, although AMH is being used often today in the clinical setting to try to predict a woman's chances of conceiving naturally or to predict when she's going to be going into menopause, the researchers are clear that that is not actually what the research tells us. That's not how we should be using this information. And they still maintain that a woman's age is the most significant factor in determining whether or not she will conceive over AMH numbers. So let's get into what is really going on here in terms of AMH. Anti-Mullerian hormone is a hormone that is produced by our ovarian follicles as they are maturing. And what happens is we are born with all the eggs that we're ever going to have. And as we go into puberty and as we kind of move through our reproductive life, every time we are gearing to ovulation, so we have our periods, we're at the beginning of the cycle, there's a small pool of primordial follicles that are developing. And the size of that pool is actually related to the total amount of eggs that we have left. So over the years, what the researchers have identified is that there is this link between how many eggs that we have in that pool of follicles that are developing at the beginning of our cycle to the total number that we have left. And they've made that connection by looking at the changes over time. So when we look at a woman's antral follicle count from when she's younger all the way through to her 40s, we can see this gradual decline. And in the same way, the AMH is actually produced by this pool of follicles. And so when they're looking at that number, they are kind of able to see the size of this pool. Now, how it's used is actually as a proxy for your ovarian reserve. And so because if they look at AMH values from younger women all the way into their 40s, there's a gradual decline. We have this correlation between the AMH and the number of estimated eggs that we have left. But keep in mind that it's always an estimate and it's always indirect, because unlike sperm testing, we can't just go in and cut out the ovary and count how many eggs that we have left, right? Like with sperm testing, they can actually have the man ejaculate into something and count the sperm. And so we get a pretty clear idea of how many sperm are in there. But we can't do that with women, obviously. And so AMH is never a direct, this is how many eggs you have left. It's always an estimate. So some of the misconceptions out there then about AMH are that it's going to predict if you're going to be able to conceive, and it's going to predict how long you have until menopause. And one of the misconceptions about it as well is that it's this static number that never changes, so it can't go up or down, and even that it's genetically inherited by your parents. And so based on this study, the researchers identify and estimate that about 50% of our capacity in terms of when we're going to hit menopause is related to genetic factors because of studies that have been done that show a similarity between, mother and daughter in terms of when they actually reach menopause. But 50% is certainly not 100. There are other studies that show that AMH is affected by other factors. AMH is affected by obesity. AMH is affected by conditions like PCOS. Women with PCOS are known to have higher AMH levels because they have a higher, bigger pool of follicles. That's one of the characteristics of PCOS, that you have polycystic ovaries. So you have multiple little follicles that are growing in the egg. And so therefore you have a higher antral follicle count and a higher AMH level. Because again, the AMH is essentially related to how many follicles are in that little pool, and they're all kind of kicking out AMH. So that's how they're looking at this number. AMH levels are also impacted by other conditions such as endometriosis. Women with endometriosis are more likely to have lower AMH levels due to all of the inflammation and complexities of the condition itself, but that doesn't necessarily correlate to her ovarian reserve directly. So what we can see, and one other study that I'll just point out, is that there are also studies that have shown, there was an interesting study that Lily and I shared in Real Food for Fertility, where the women were given vitamin D at a certain time of their cycle, towards the beginning of their cycle, and it actually increased the AMH levels over a period of time. So the reason I'm pointing that out is because one of the common misconceptions about AMH is that it's static and it doesn't change. So the misconception is that it's set in stone. But as we can see, we have all these examples of how it can actually change or respond to different conditions. So while we do have a correlation between AMH levels and the ovarian reserve, it is not this direct, this means that we can predict exactly when you're going to go into menopause. And then the other piece of it that's really important is that this number is estimating your reserve. So it's estimating how many eggs that you have left. Again, estimate is an important word in that sentence, but it's also a quantity thing. So that means that even if you have a low number, that doesn't automatically mean that the quality of those eggs is also low. And so interestingly, then, when these authors and researchers in this paper, when they are reviewing the data and they're outlining how the AMH number should be used, they are crystal clear on a few points. They're crystal clear on the point that it is not actually predictive of your reproductive capacity, how likely you are to get pregnant. And it also can't be directly used to predict when you're going to be going into menopause. And so I'm sure that at least some of you listening to this episode have been told the exact opposite thing. And so, the good news is that, like I said, you can go to the show notes page and you can have a look at the paper, and there's a lot of research on this. This is not difficult to find. For those of you who are really into the research literature, it's really easy to find because this is not a hidden thing. There's a lot of research on AMH, and the conclusion is crystal clear. And that is what makes it really interesting for me when I hear so many of my clients being told that, well, my doctor told me that I'm going to go into menopause. My doctor told me that I won't be able to have kids. My doctor told me blah, blah, blah. And it's just like, unfortunately, as we know, it takes up to 2 decades for the latest research to get into clinical practice, into standard clinical practice. So we do have to keep that in mind as we go through these studies that are pretty coming out. This study that I'm going through today was published in 2022. So like I said, this is not new information. This is pretty standard. Popping into today's episode to let you know about our newest resource for women's health professionals, the Practitioner's Guide to Optimizing Egg Quality. This comprehensive guide breaks down the 5 key steps to improving egg quality, along with the top 5 evidence-based supplements to support egg development, mitochondrial health, and implantation potential. Head over to fertilityfriday.com/egg-quality to grab your complimentary copy today. That's fertilityfriday.com/egg-quality. Now let's go ahead and jump back into today's episode. So I guess this brings us to the question, so then what is AMH used for? What are the clinical applications and what are the best uses of this number? And so I think what's really important to understand is that the research shows that the best use of AMH, like what it is best used for, is for clients who are undergoing ART, assisted reproductive technology. So for example, if you're going through IVF or you're planning to, and they test your AMH whether it's low or high, it's going to be an excellent predictor of how many eggs they're likely to retrieve. There's a really, really strong correlation between that AMH number and how successful that retrieval is going to be, how receptive your ovary is going to be to the stimulation, and how many eggs that they're going to be able to retrieve. And again, the reason for that is because when the AMH number is low, it's saying that the little follicle pool, so the pool of antral follicles towards the beginning of your cycle, is low. So if there's a pool of eggs and the pool is very, very small, well, the amount of eggs that they'll be able to stimulate through the IVF process is going to be directly related to how many eggs are actually in that pool. So it makes perfect sense that that number correlates really well with how many eggs that they're able to successfully stimulate and retrieve, right? And if the AMH levels are normal, if they're in that optimal range, then you're a good candidate for that stimulation process. And conversely, if your AMH levels are too high, which is commonly seen in PCOS, because again, that is related to this polycystic ovary situation where we have a lot of little follicles developing but aren't necessarily reaching maturity, which is characteristic of the condition. What you have then is the situation where you have too many, and that can lead to a greater chance of hyperstimulation, which is, it can be a very serious condition. It can even be fatal in very severe cases where they're stimulating the ovary and there's so many eggs in that pool that it can kind of cause a lot of pain and a lot of discomfort and that kind of thing. So in the paper, what the authors talk about is how then one of the best applications for the AMH is specifically related to IVF procedures, and to let the clinicians, if they see certain numbers, they're able to gauge the dosing. They're able to be more specific and precise with how they're going to approach that stimulation. And potentially, if a woman has a higher number, they may change how they're going to dose so that she's less likely to overstimulate. And they're so crystal clear. Let me read a few things. Let me read a couple of quotes here. So they say, serum AMH estimates ovarian reserve, helps determine dosing in ovarian stimulation, and predicts stimulation response. And they say, as such, AMH is a good marker of oocyte quantity. Again, the amount, how many, but does not reflect oocyte health or chances for pregnancy. So could we be more clear that it has this utility for these procedures and predicting not, and this is one thing that's really important, it doesn't have the utility to predict if that pregnancy is going to go to term, but it can predict whether or not the woman will be receptive to the stimulation and how many eggs likely will result from that. I mean, these are really important factors. So for example, if you are not planning to do IVF, or if your client is not planning to do IVF, or that's not their preferred, at least at this time, that's not their primary goal, then that AMH number is not as helpful because it doesn't actually tell her if she's likely to get pregnant naturally. It actually doesn't tell them that. And interestingly, there are research studies that have been done where they compare the pregnancy rates of women with higher and lower AMH levels. And typically it's not that one is related to another. So if I take a moment to read a brief section from Real Food for Fertility, outside of IVF and ICSI procedures, AMH is similarly a poor predictor of a woman's ability to conceive naturally. In an observational study of 87 women planning to conceive, 88% conceived within 1 year, and the researchers found no relationship between AMH levels and time to pregnancy. So I think this is the point, right? This is always the point that I want to share when it comes to AMH and how we should be looking at it and how we should be talking about it, how we should be understanding it, interpreting the results. The authors of this paper go so far as to say that women who are not seeking IVF treatments, I mean, their language was kind of like women who are not in the infertile population, so very like researchy. But what they're saying is like, if you're dealing with a normal, healthy woman who's trying to conceive naturally, and there aren't specific signs potentially of infertility, that it shouldn't necessarily even be used because there's no research to show that it's going to help in any way to predict if she's going to conceive or not. And they go on to really stress that age is still the biggest factor. So one of the things that they talk about is that as we get older, we are more likely then to have chromosomal abnormalities, all these things that a lot of us are aware of. And ultimately, if you are trying to conceive naturally, that's the route that you're trying to take, then it would make a lot more sense to focus on strategies to support egg quality. So whether that's strategies to support mitochondrial health, to reduce oxidative stress, which is damage due to oxygen exposure. And the example I always give is if you take out a banana and you leave it on the counter, it turns brown. But if you dip it in lemon water or like lemon juice or something like that, it doesn't. And that's because vitamin C is a potent antioxidant. And so therefore it's protective. And so if we have an understanding that these numbers are not telling us about the quality and instead they're just telling us about the quantity, then we can focus on the thing that is likely going to make the biggest difference, which is supporting nutrient reserves, working on improving egg quality, and of course, really focusing on improving sperm quality as well. So I'll just share a couple other direct quotes from the study because, again, just to kind of like put the nail in the coffin here. So one of the things the researchers said, AMH is a good marker of oocyte quantity, but does not reflect oocyte health or chances for pregnancy. And another quote from the paper, there was no AMH level below which pregnancy did not occur. There are recorded in the literature, in the research, pregnancies that occur even when women's AMH levels are undetectable. And so while that isn't necessarily the best situation, I think that if the AMH levels are low, there is room certainly to be supporting egg quality, really looking at nutrition. A lot of the things that we talk about in the egg quality chapter of Real Food for Fertility and the nutritional strategies that we talk about throughout can be helpful, of course, and looking at sperm quality as well. But ultimately, the research is not showing this direct link, this causative effect that if the AMH is low, that natural pregnancy can't occur, or that if AMH is low, if pregnancy does occur, that it has any predictive value on how likely that pregnancy is to go to term. And so again, the most useful way to use this information would be to determine the approach that your practitioner would be taking to IVF procedures. So in many ways, this is good news. It's good news for women who are trying to conceive. It allows them to kind of step out of the fear around this number and these results that is often perpetuated to them, at them, and allows them to refocus on what's most important. As practitioners, it's helpful for us to have a clear understanding so that when our clients are coming to us with these types of issues, we know how to support them. And it's a good reminder that we really should be looking at the research and the literature and understanding the true implications of it. Now, I think when they first discovered it, there was all of this excitement. We're going to be able to predict when women are going into menopause. And it was kind of like this, like the promise, I suppose, was that. And that may have been how it was presented decades ago. But now we have a lot more data on it, and it really changes how this conversation should be had. And for many of your clients, this is not, it hasn't, just because it's changed and updated in the literature, doesn't mean that it's changing their experience. And this is a common challenge for practitioners who are working with fertility clients. So again, if you're wanting to dive into the study that we talked about today, you'll find that in the show notes, fertilityfriday.com/595. If this episode was, if you can think of someone, if there's someone who comes to mind when you hear this episode, then I would encourage you to share it. And like I said, if you're wanting to do a deep dive and to go, way more into egg quality and sperm quality and all those things, I would certainly direct you to Real Food for Fertility. If you haven't grabbed your copy yet, you can head over to realfoodforfertility.com and get the first chapter for free. Otherwise, you can find it on Amazon, and we also have the audiobook version. So it's there for you when you are ready to take a deeper dive into it. So with that said, I hope you have a wonderful weekend whenever you tune into the show. And until next time, be well and happy charting. If you're loving the podcast and you're ready to apply fertility awareness strategies in your women's health practice, then I know you'll love our Fertility Awareness Mastery Mentorship. It's a 9-month immersive experience that will completely transform the way you work with clients, allowing you to not only teach fertility awareness, but to use the menstrual cycle as a vital sign and diagnostic tool in your women's health practice. Our next class starts in January 2026, so there's still time to reserve your spot. There's no other program like this offered anywhere. Transform your practice in 9 months. Head over to fertilityfriday.com/FAMM to apply now. That's fertilityfriday.com/FAMMLIVE.